So good day, good night, everyone. Welcome to our weekly session of Virtual Global Spine Conference. This time I have the pleasure of hosting a very close friend of mine, Facundo and Isseldyk from Rosario in Argentina. He's a phenomenal surgeon. He's focused mostly entirely to endoscopic surgery. He's a very prominent spine surgeon in my country and also in the region. So when I asked Facundo to come, he proposed this planning and execution of tailored approaches, and was kind of a sexy name. So I'm pretty interested in see what are you gonna show us tonight. So without further introduction, welcome, Facundo. It's a pleasure to have you. And
no,
it's free.
The pleasure is all mine. I'm actually really happy to be here. You know what? I'm a follower of Virtual Global Spine. I saw all the episodes, if we can say that, and knowing the people who spoke here and the level of the presentations, I must say I'm a little intimidated. So I will try to make honor to this great webinar. And thank you, Alfredo, for the invitation. As Alfredo said, I'm also a spine surgeon, and despite I'm mostly devoted to endoscopic spine surgery, I started my practice with open surgery. And we learned with open surgery that there is no rigid surgery. We must adapt our surgery to the individual patient. And the thing is that when you start doing endoscopic surgery, endoscopic procedures are presented as rigid procedures. And I know that's a way to make the learning curve more easier. But the thing is that to explode the whole potential of the endoscopic surgery, we need to deconstruct that rigid system of learning and try to do a surgery that is totally adapted to the patient's need. So that's why I chose this sexy term for the for the presentation. Before continuing, I don't have any financial disclosures or whatsoever, and as we were speaking before, I think we can all agree that endoscopic surgery is becoming more and more popular nowadays, and with this increasing popularity, there's a growing concern about how hard is to teach and learn endoscopic surgery. You know, there's a lot of papers written about this thing here on the screen, that it's a learning curve, that is only the graphic representation on how much time do we need to invest in order to gain proficiency in a certain technique. And you will find a lot of studies and papers, and they all agree in one single thing, that the learning curve of endoscopic surgery, it at least is complex. And it was already complex when the endoscopic surgery started like 30 years ago. And now with the so-called third generation endoscopic procedures, which are more demanding technically and technologically, the learning curve is getting more and more complex. So when we teach endoscopic surgery, we tend to do it in 3 different levels. Because taking directly into these third generation procedures it could be a real disaster with surgeons getting frustrated and just dropping out of endoscopic surgery. So we organize the teaching and the learning into 3 different levels. And that's what we like to call the first one, the immersion in endoscopic surgery, that it's also called the Endoscopic Spine Surgeon Starter Pack. It's the basic concepts and the first contact the surgeon has with even with an endoscope. So for many surgeons, this immersion step is done in one of the most industry-driven courses that you can find. The idea is not to make the enough proficiency in order to the surgeon to perform a surgery. The idea is to just give a general idea of what the endoscopic surgery is and what it can do. So it's mostly based and focused on endoscopic approaches. And soon enough, the trainee starts to think in how can I do this puncture safer, and how can I take this hernia endoscopically, and start to learn a lot of new terms like SAP, AAP, which they're not really new, just we use it a lot. So this is like the first contact with the endoscopic surgery, but again, it's not enough to do an actual surgery. So the second step is what we call the consolidation. The consolidation is going from the basics to learning how to do approaches and procedures in a really effective way. In this step, we tried that the surgeon can perform certain procedures like endoscopic discectomy, endoscopic lateral recess, decompression from start to finish in an effective way. So in order to do that, we need to present the surgeries as a recipe in a stepwise fashion. Like you do step 1, step 2, step 3, and you finish the surgery, and that's all. You don't get to do any variations, and you don't get to adapt anything. It's rigid, but it works in this stage of the surgeon's formation. So what I think is that soon enough, the trainees start to realize that we have like one solution for every problem. So you have problem A, you can solve it with the approach A. You have problem B, you can solve it with approach B. The problem is that as you go on and on, the variation of the patient's problems and pathologies, it's huge. So it's not possible to design a rigid scheme to treat every variation in the pathology. So the idea is that to deconstruct that rigid approaches and teach the trainee that there's no a single surgery. Instead, the surgery is composed of different components that can be rearranged to fit the patient's needs. So you can treat every surgery as a combination of different modules that can be rearranged to adapt to the patient's pathology. This is what we call the step 3, that is called deconstruction. And that's the reason why we are giving this presentation today. It's not easy, but it's necessary to explore the maximum potential of the endoscopic surgery. So, as we said in the beginning, endoscopic surgery has approaches, and they can be divided in mainly 2 groups, interlaminar, and we can call them transcambing or transforaminal. But the idea is that the interlaminar uses the interlaminar window as an anatomical pathway to do the surgery, and the transcambing do the same with the safety triangle of cambing. We're going to take this into the practice and start describing how you can do a tailor approach using the interlaminar approach to the spine. Yeah. So, you know, the basic form of the interlaminar approach is the interlaminar access to L5S1, a lateral disc herniation, for example. That's not casual. The easiness of the surgery at the L5S1 has a really really concrete reason. You have here the key point of every interlaminar access. That's the traversing nerve root shoulder. If you can access the shoulder, you can mobilize the nerve root, you can access the disc space, and you can do a decompression. So basically, the key to every interlaminar access is the nerve root shoulder. The reason that is behind we start with endoscopic approaches, interlaminar approaches in L5S1 when we teach endoscopic surgery is that basically the dimensions of the interlaminar window at L5S1 allows us to directly contact the nerve root shoulder just by opening the ligamentum flavum. It's already there, so you only have to open the flavum, locate the shoulder, do the mobilization of the nerve root, and then you have the surgery done. For example, look at this voluminous disc herniation at L5S1. The surgical strategy will be you do your standard medial skin incision, you go to open the flavum, you mobilize the nerve root, and then you extract the disc herniation. So this is how you do it. You just land into the ligamentum flavum, go lateral until you reach the deep layer of the ligamentum flavum, and then you unroof the lateral recess. In this level, the lateral recess is mostly roofed by the deep layer of the ligamentum flavum. So you cut the ligamentum flavum with your scissors, your curves and rongeurs, and then you identify the nerve root shoulder using your punches, mobilize the nerve root and access the disc, and then take out the disc herniation. And that's all. It looks very simple, but the problem is that when you try to do the same in other level, or maybe in a not so wide L5S1 interlaminar window, the problem starts. The nerve root shoulder is not as accessible as it was on the previous level. So you need to drill your way to the root shoulder. So how much drilling do you need to do? Okay, this is possible to calculate. You can do it in a AP X-ray by measuring the distance from the interlaminar window shadow to the medial pedicular line. But the idea is that in this stage of the surgery, you only drill what's necessary to access the nerve root. So let's take into consideration this case. You have not an L4 or 5, you have a 2-3 disc herniation. And let's assume you want to do it interlaminarly. So what you need to do is not only your previous strategy, but to add some 2 modules that allow you to access the nerve root shoulder. That's going to be the AIP drilling and the SIP drilling. So here's the video of the surgery. You're going to start drilling the AIP in order to widen the interlaminar window. The idea is try to transform this into not the L5S1, because that would be too much, but to expose the shoulder of the nerve root. The following steps are the same. You just open the flavum ligament. Here you do it carefully because the dural sac is bigger, and you just going to find your shoulder just lateral to the nerve root. You open it carefully, and then you do the same thing. You mobilize the nerve root and access the disc space. But what about when you have another kind of pathology? You have, for example, lateral recess stenosis. Here, it's not enough to just take out disc herniation or open the ligamentum flavum. This kind of pathology requires a wider exposure of the level. So here, it's not enough to just expose the shoulder. We are going to have to detach the ligamentum flavum from the AIP, from the laminae, and from the SAP. So your drilling is going to be bigger. So your previous strategy is going to be modified, and you are going to have to drill a lot of lamina in order to detach the ligamentum flavum. And you're going to change this, which is flavum opening, for flavum removal. As we are not going to remove disc herniation, there's no need to go into the disc and mobilize the nerve root. So here's the video. This was a patient who had an interspinous device. So this was really a great intervention considering the previous open surgery. There you had the lamina and the AIP, and you start drilling. The white color of all the tissues is because the fibrosis. So you have to drill the lamina until you see the detachment of the ligamentum flavum. As you can see here, the ligamentum flavum is firmly adhered to the right lamina, and when you reach the level of the attachment, it's going to loose like this, and you're going to be into the canal. So then just by gently drilling and pushing, you can detach the ligamentum flavum from the lamina and the AIP, and then you can remove it. As usual, you can do it piecemeal, or you can do it like in a block. There's no difference, it's up to you. And then we go and search for the nerve root projection and release the nerve root from the remaining ligamentum flavum. So the idea here is to decompress, to do a posterior decompression endoscopically by detaching the ligamentum flavum. And the objective here is not to reach the disc space, is to observe the nerve root free from shoulder to axilla. Here you see shoulder and axilla free. But that's not the whole potential of the interlaminar approach. We can do contralateral decompressions, and the contralateral decompression is known from the tubular approaches or open approaches as over the top. So the idea in this case, for example, this is a case with another interspinous device and stable listhesis who had bilateral lateral recess stenosis. So we need to modify our approach and just put together all the things we did in the ipsilateral decompression of the lateral recess. Then we are going to add the ipsilateral flavum removal, but then we're going to add the spinous-based drilling. This is going to give us space to cross to the other side and to correctly put the endoscope in order to perform a contralateral SAP drilling and a contralateral flavum removal. So that's the plan. And how do we do that? Well, we start with the same side as we did before, just drilling the attachment of the ligamentum flavum. We drill really carefully of the fibrosis. Here, remember that this patient was operated before. So we start doing the decompression of the lamina and the AIP. Then we drill to enlarge our side, our ipsilateral side, and we start drilling the spinous base process. Then we make ourselves space to correctly maneuver the endoscope and cross to the other side and drill and take out the flavum ligament from the other side. So the idea here is to not to sacrifice facet joint, but to sacrifice the spinous base process. Here we are finishing the removal of the ligamentum flavum cranially. And this is the final view with the whole dural sac completely free from shoulder to shoulder. But what about this kind of patients when you have like a foraminal stenosis and you can't reach that from a transforaminal approach because you have a high iliac crest or maybe scoliosis? So we can plan a contralateral approach, and that's actually a very clever approach, and it's a variation of the usual interlaminar approach that we use. This patient had a stable listhesis, a lytic listhesis. You can see here the lysis of the pedicle. Here we have our usual plan when we do an over-the-top surgery, but we are going to modify that, and we're going to just target our contralateral SAP. That's our decompression target. So we are going to first place our skin incision a little lateral, and then we're going to widen our spinous process base resection in order to have more mobility to reach the contralateral SAP. So our strategy is going to get like this. We're going to do a paramedial skin incision. We are going to take out the ipsilateral maneuvers. We're going to do a spinous base drilling, and then we're going to contralateral. So this is the video of the surgery and the surgical plan. As we said before, sometimes the transforaminal approaches are not feasible because of anatomical impediments. So here you have the target, our occluded right L5S1 foramen, and our plan to go interlaminar contralateral to the other side. So we are going to start by doing a ligamentum flavum dissection. And then we're going to navigate until our slipped AIP and SIP come into view. So here we have the right lamina and the superficial layer of the ligamentum flavum. We're going to start drilling, and then we're going to detach them as we did in the previous surgery, but without doing anything on our ipsilateral side. Here we are going to find that you have a direct view on the lysis zone. You can confuse the lysis zone with a facet joint, but this is actually the lysis between the isthmus and the AIP. So you start drilling your AIP, contralateral AIP, and you're going to find behind that AIP, you're going to find your contralateral SIP. You start the drilling, and here you have your contralateral SIP. The nerve root, the L5 nerve root, is covered by the SIP, so you had to gently drill it and mobilize it here. And then you start taking out the SIP, the contralateral SIP, with the nerve root in view. The idea is to follow the nerve root into the foramen and then decompress the foramen too. So here we are dissecting the nerve root, and then we are completing the drilling of the SAP and completing the decompression of the L5 nerve root. You're going to know that the idea here is to follow the nerve root and decompress everything that is touching it. So here you have it, the L5 nerve root with the AIP and the SIP drill going out of the foramen. And look at when we take out the endoscope, this is the tunnel that we made to reach the contralateral side. This is the post-op CT scan. You have the comparison here and here. So what happens if we not only have to address a contralateral foraminal stenosis, but we also have an anterior compression, so like a L5S1 disc. You know, there's not enough with the SIP decompression. We need to add an anterior decompression, and we can do that by working in the contralateral Campbell's triangle by just going down into the zone between the transverse nerve root, the contralateral transverse nerve root, and the contralateral exiting nerve root. So our strategy here will be not only going to the flabum removal, but also to go into the contralateral Campbell's triangle and remove the disc herniation. So here you're going to have our rational thinking behind why do we choose this kind of approach. You have the patient's imaging here. There's a compression of the foramen, so we could go transforaminal, but that would be impossible because of the iliac crest is blocking our side. So the other option is to go posterolateral, but the amount of facet joint that we need to resect is going to be high, and we can compromise the stability of the segment. That's why we choose to do the contralateral interlaminar, which is this kind of approach that maximizes the reaches of the interlaminar approach. So here you have again our initial steps on our targets: the disc herniation and the SIP compressing the nerve root. The idea is that when you have decompressed the SIP, you're going to work into the contralateral Campbell's triangle by putting your endoscope with your working sheet protecting the S1 nerve root and the camera facing the L5. So you have the camera protecting the L5 and the working sheet protecting the S1. Here we are closing to the lower side. We just skipped all the previous steps. We are taking out the flavum in an open book fashion in block. We do like this under the flavum dissection, then we cut the attachment to the SIP and we take the whole flavum. And then we have here this S1 nerve root, the disc, and the SIP. So we start to follow the disc laterally. And when we follow the disc laterally, we will find the L5 nerve root. We start then decompressing the nerve root from the posterior compression. And then we we position our endoscope in order to see the L5 nerve root and protect with the bevel the S1 nerve root. That's why we can drill this osteophyte and disc herniation in a safe way, because we are covering the S1 nerve root with a bevel and we are watching directly the L5 nerve root. So here you have it. We are just releasing that calcified disc herniation, and we are releasing the anterior compression of the L5 nerve root. We can then take out the remaining soft tissue, annulus, and rest of calcified disc with a Curson rongeur, and then you have it. That's the final view of the extraforaminal portion of the L5. Here you have it from the foraminal to the extraforaminal, all decompressed. And then you have both roots in view. You have 5 and 1, 5 exceeding the extraforaminal area, and S1 going into the lateral recess to S1 foramen. This is a post-op CT scan showing the amount of resection. This is a comparison between the pre and post. So that's all about the combinations of the interlaminar approaches. Actually, we can do more kind of variations, but it's up to the patient's pathology. So you can just add and subtract modules in order to just do what the patient needs, no more and no less. Well, now to talk about transforaminal approaches, you know, the transforaminal or transcambing approaches, they are a group of approaches who share a common characteristic. They all take advantage of the Cambian's triangle, the Cambian's safety zone, to go into the target, for example, a disc herniation, and remove that. But the way they reach that safety triangle is an X-ray guided puncture. So we need to first address one or two things about the puncture, because our first important decision to make when designing a tailored approach, a tailored transforaminal approach, is what are we going to do with our puncture, what is going to be the entry side, and what is going to be the target. So this is really important, because our function is going to define the reach and limitations of our transforaminal approach, but also is going to modify our perspective of the different structures of the foramen, and will also define our landing side. That is the initial area in which our endoscope is going to land. So let's take, for example, this case. This is an L4, L5 medial huge disc herniation. So let's assume you're going to operate this patient with a transforaminal approach. Okay, so first of all, you need to define the target. So this is going to be your target area, your disc herniation, the lateral margin of the disc herniation. In order to plan your puncture, you need to remind that your endoscope, although it has 30 degrees visualization, it's basically a straight instrument. And the same thing is for the needle. They're both straight instruments, so they move along a line. So when you're planning your puncture, you need to align your target area the safety triangle and the skin entry sign in the same line. So here you're going to have both exiting and traversing nerve root. In green, you're going to find the safety zone. Here's your target. So if you put a line from here, passing through the facet joint into the skin, you're going to find your skin entry zone. So this approach here, it goes from the outside without touching, without removing the facet joint. This is one option. You can also do a more medial approach that implies the resection of part of the facet joint. That's also an option, and any surgeon can choose it if he or she wants. But it seems like the lateral entry side is simpler because you just dodge the idea of drilling the facet joint and you go straight into the disc. But the thing is that every time you change your entry side and you go lateral or medial, you change also your perspective. So, for example, you can also choose to do a more medial entry side here because you need to remove facet joint because it's part of your pathology. This is another case in which you don't have only anterior compression, but you have in the foramen, you have some sort of stenosis that combined with this herniation, you need to remove in order to release the excident nerve root. But the thing is that when you go lateral medial, your view changes. This is most lateral. This is a transforaminal approach at approximately 10 centimeters in L4-L5, and this is at 8 centimeters at L4-L5. So if you think this into consideration, if you take this into consideration, you will see that the perspective changes enormously. When you go lateral, you have a portion of your traversing nerve root going into the view of the endoscope. And if you go medial, that traversing nerve root starts to hide behind the facet joint. So you just going to have more reach medially with the lateral axis, but you're going to lose some sort of posterior control because you're not going to be able to resect the posterior margins of the facet joint. If you go medial, you will have less medial resection power, but you will have more anterior and posterior control. So it depends on what kind of pathology do you want to address. So here we need to take back to this concept of transforaminal approaches and revise this concept of Cambis triangle, because the main temptation of every surgeon, of every endoscopic surgeon, is to go straight into the pathology. For example, if you have here a disc herniation, the idea would be, okay, I go with my needle into the disc herniation and take out the disc herniation. Okay, that could be a great mistake because we are confident that we are going through a safety area, and that's not always the case. According to this and other studies, you only have a triangle that is big enough to allow your endoscope to pass in the 20% of cases. In the remaining 70% of cases, the safety area is going to be small. You're not going to be able to go into the disc space or the safety area without damaging a nerve root. That could be the exiting of the transversing. It doesn't matter. So the idea is the following: is that when you do your endoscopic insertion and puncture, if you do it directly here, and you are lucky, you're going to be able to go inside the disc without damaging the nerve root, because you have your 20% of big safety triangle. But if you're not lucky enough and you are in the remaining 70, that's a wrong number here. You have a 70% chances of just damaging the nerve root in your insertion. So what's the idea here? Is that you don't put the point of your needle directly into the target. You just put the point of your needle and your endoscope in the SAP. You start your endoscopic visualization, and then you go down, you mobilize the nerve root, and then you go inside the disc, or you go to look for the fragment. But this is the way to do it without damaging the nerve root. So and in the MRI, it will look like this. Just puncture the SAP and then go inside your target, but with direct endoscopic visualization, not with X-ray. In this way, you won't be able to damage the nerve root. So when talking about modules and Taylor approaches in the transforaminal approach, it's really easier than the interlaminar, because you'll have just a number of separate procedures that you can do in the foramen in order to rearrange the two diameters of the foramen. So you can do an SAP tip resection to release the posterior compression of a patient. You can do a lateral recess transforaminal decompression. That's to enlarge your anteroposterior diameter, but in the lateral recess. And you can do also anterior decompression, like taking out a hernia in the extra foramen or foramen, or even in the lateral recess. There is only one maneuver that can enlarge the cephalocaudal diameter of the foramen, and that's the partial pediculectomy. And I must say, it's not always effective. I think that we have concluded with other endoscopists that when you have like a big reduction in your craniocaudal diameter of the foramen, it may be wiser to just go and do an interbody lumbar fusion and reestablish those diameters by putting a cage. So these procedures can be rearranged in order to match the pathology of the patients. Here you will find, for example, one case in which the pathology was a cage, a migrated cage. Here, the tip of the cage was compressing the exiting nerve root in L4-5. And we did exactly what we talked earlier. We started our endoscopic surgery in the SAP, and then we go down to the root level in direct view by mobilizing the nerve root with a bevel. So you put your bevel in the space between the nerve root and the cage, you mobilize the nerve root, and then you access the cage in the same style that you used to do it in the interlaminar fashion. We then expose the cage, see if we can put it back in, and it was no mobile. We remove some of the osteophytes, and then we decided to just drill the portion of the cage which was compressing the nerve root. So here you have a targeted transforaminal approach, which has only 2 steps or 2 models. once you release your nerve root, you can see that now you have a space between the nerve root and the foramen and the cage. This is another case, and we are going to start finishing our presentation. This is a lovely lady of 75 years old. She is a yoga teacher, and she describes very well the pain that she has. It was an incapacitating pain, disabling pain. And this is what was causing the pain. Let's see that again, or slowly. You have foraminal stenosis, a severe foraminal stenosis that is caused by a osteophyte, a pseudo-disc herniation, and unstable listhesis. You have the X-ray here. So this is the plan. We start by doing an SAP docking. That was what we discussed earlier when we just start our endoscopic surgery here, and then we go to the nerve root area with direct endoscopic visualization. Then we dissect the foramen, remove the osteophyte, uncover the disc space, and then we go for the other osteophyte. And then we address the soft tissue compressing the R4F root. Again, we start by docking our working sheet in the SAP, and we start dissecting, and then we fall into the foramen. Here you can see the nerve root protected by the bevel and the end plate and the osteophyte. So we start the drilling process in order to cavitate and remove the osteophyte. We do the endocavitation of the osteophyte, and then we break down the osteophyte from the outside to the inside to protect the nerve root. We can do a little leverage with the bevel of the working sheet, and we continue our drilling towards medial because we need to reach the lateral recess. We continue drilling until we see the disc space, the collapsed disc space. That white line there, that's the disc space. So once we reach the disc space, we now start to address the L4 osteophyte to remove the portion of the L4 osteophyte that was compressing the nerve root. So again, we are protecting the nerve root with the bevel. We start drilling. And now we have both osteophytes removed. We're going to go to remove the soft tissue that is compressing the nerve root. So here you have it. We are checking out the wellness of the nerve root. We are shrinking the soft tissue with the coagulator and then remove it with rongeurs. And finally dissecting the final additions of the soft tissue to the nerve root. Our final view is shows the space that we created between the nerve root and the listhesis. And here is the postoperative comparison between the stenosis that she had with the newly foramen that we did here. You can check the removal of this portion of the osteophyte here that was compressing the nerve root. Here's the difference in the 3D CT scan. So some final thoughts about this presentation. I'm borrowing this phrase from Luke Kim. Endoscopic surgery is not the panacea. Sometimes it's not possible to address the patient pathology with endoscopic surgery. So doing a tailored approach is to maximize and fully explore the potential of endoscopic surgery. But as any surgery, the endoscopic surgery has limitations. So this is not a creativity contest. The idea here is to work with other physicians that do other techniques, and between the whole team decide which option is the best for the patient. I mostly devoted to endoscopic surgery, but I work with excellent orthopedic surgeons and neurosurgeons who do fusion surgery, who do XLIF, ALIF, and all the techniques that are available. So when we decide that endoscopic surgery is not the best approach, we just do other surgical techniques, and that's why this shouldn't be one of those situations in which your imagination is a limit. It's the contrary. The limit is actually the patient's safety, and the objective, as always, is the patient's wellness. So I want to thank again for your invitation, Alfredo, and for having me here. I know endoscopic videos can be a little can cause a little dizziness and be a little boring, but I hope you guys enjoy the presentation. Thanks.
Thanks, Facundo. That was a phenomenal presentation as always, and I always learn something from you in the different lectures I saw from you, and I think it's curious or it's funny to see how spine surgeons think the same pathology in completely different ways. So we saw a lot of lectures from different surgeons that are pretty renowned surgeons in the world, and some deformity surgeons always talk about full spine X-rays and how to match different numbers and spinopelvic parameters, and a lot of reconstructions and fusion, and see that everything is unstable and need a reconstruction. And we don't see videos and we don't see nerves. And when we see endoscopic lectures, we see a lot of videos and a lot of nerves, but we don't see full spine X-rays and everything is stable. So it's the same problem and can be addressed in completely different ways. So it's good to see how endoscopic is pushing the limits for indications. Every single technique in the world has been pushed for someone sometimes, and that's now the gold standard. So I see a lot of potential in this. We'll see in the future, but thanks for the videos. I always acknowledge this kind of recordings. It's a lot of work to record this. It's a lot of work to plan every single case that you did, and that was pretty amazing. I have two short questions for you because we're in time. When you do foraminoplasty, you only drill like I guess standard procedure, right? You only drill the tip of the superior articular process, or you drill the anterior portion of the superior articular process as well?
Oh, first I have to be fair, because otherwise Luke Kim is going to not like this. The term foraminoplasty is almost abandoned right now. We are just unifying everything in foraminotomy. I know it seems like something without importance, but actually one of the things that is happening with endoscopic surgery today is we have a lot of names to describe the same thing. So you can find it's really hard to search in the literature. For example, when doing a meta-analysis or a systematic review, because you have like 4 names for the same thing. So the foraminotomy is the technique when you modify the foramen, whether it's osseous or it's soft tissue, in order to create a space and allow the exiting nerve root to be released. So answering your question, yeah, we only, when we need to just decompress the exiting nerve root, we just decompress the tip of the SAP. The thing is that sometimes you have foraminal compression that is affecting the exiting nerve root, and then you have lateral recess compression that is affecting the transverse nerve root. So you can do both in the same approach. But in order to do that, you have to first drill the SAP tip and then continue into medial and remove like the ventral area. Yeah, and then release the flavum ligament, because if you only do a bony decompression in the foramen or in the lateral recess, you are not solving the pathology. You have to do the drilling and then take out the flavum ligament.
Got it. So, Hank, we all see in these videos the nerves that looks decompressed in the prone position, in a particular opening space position. How do you know the decompression is enough to get a good result when the patient is standing?
Oh, first, that's an excellent question, because I think that's the main issue we need to solve now. The famous benefit zone of the endoscopic surgery, especially when dealing with deformities. We try to estimate if the spine changes in the standing position by ordering some standing X-rays and a spinogram, but that's not enough. We have seen that some craniocaudal reductions in the foramen are not easily decompressed, because even when it seems in the X-ray that the X spine is not moving, you do partial pediculectomy. You restore the dimensions of the foramen in the craniocaudal dimensions, and then the patient sometimes remains with pain, or start with pain like 2 or 3 months after the surgery. So we're trying to define which of those patients is going to be is going to benefit from an endoscopic surgery, and which of them is going to just need a standard surgery, fusion. like fusion. Yeah.
Awesome. Well, thank you very much. I really appreciate your time. This kind of presentation takes a lot of time. So you're gonna have it available in YouTube from tomorrow on, so you can go through the presentation back and with time to study from it. It's a good manual.
You mean torturing myself?
No, not yourself. We have a last question from Carlos La. He's a friend. Standing MRI, that would be the panacea for all of us. To know how the foraminal diameter behaves when you're standing, but we don't have it available widely. But that would be a phenomenal idea. Yeah. So thanks, Facu. See you later. Appreciate it.
Thank you so much for having me here. Thanks.
Bye, everyone. See you next Thursday.